everyone, today we're going to be talking about EKGs and how they relate to heart physiology. We're going to start off with a heart anatomy refresher, highlighting the most relevant regions to an EKG. Blood will enter the right atrium through the inferior and superior vena cava and pass through the right AV valve to the right ventricle. It will then move through the pulmonary valve to the lungs for oxygenation. It will return to the left atrium and pass through the left AV valve into the left ventricle. It will then go through the aortic valve, through the aorta, and out into our systemic circulation. There are three autorhythmic centers of the heart that are responsible for creating and propagating electrical signals that will lead to heart contraction and relaxation. These electrical signals are what an EKG is actually measuring and can indicate the strength and functioning of our heart. The first node is the SA node, or the pacemaker of the heart. The SA node is located in the right atrium and will create an initial depolarizing wave that will spread to the AV node and Purkinje fibers. The AV node will receive the signal from the SA node and will transmit it from the atria to the ventricles. This is a clinically important node for ensuring depolarizations of the atria and ventricles are coordinated, and this is something that is often of interest when we're looking at an EKG. Finally, the Purkinje fibers are located in the interventricular septum and will make sure that the electrical signal reaches all areas of the ventricle. So as I mentioned, an EKG measures the electrical transmission of depolarizations across the heart. This is what an EKG looks like down at the bottom of the screen here. There are three major landmarks that you will become familiar with. First the P wave, then the QRS complex, followed by the T wave. Note that depolarizations coordinate with systolic contractions and repolarizations coordinate with diastolic relaxations. So when you're working through EKG problems, I really want you to think back to this relationship between EKG and volume and pressure. This is a major source of confusion for some students, but I think that understanding the nuances in this relationship will really help you understand what's going on in the cardiac cycle at certain points on the EKG. Note that electrical depolarization leads to volume and pressure changes in the heart chambers. EKG does not directly measure changes in volume or pressure, but you can use the connection between depolarization and heart contraction to work through events at each EKG landmark. Really the key here to understanding this is noting that there is a slight lag between depolarization and contraction. Some students assume that EKG peaks correlate directly with pressure peaks, but this is not the case. The pressure peak should follow slightly after EKG peaks due to this lag. Pause your video and think about this question. What might happen if electrical conduction between nodes was disrupted? We will circle back to this later. So the P wave is the first landmark on an EKG. It represents the electrical excitation from the SA node that is depolarized the atria. There is a lag of about 100 milliseconds after the P wave that leads to atrial systole, and this occurs at the PQ segment highlighted below. So the second landmark, the QRS complex, indicates that electrical signal has propagated from the SA node to the AV node and Purkinje fibers, which results in ventricular depolarization. Again, there is a lag between this depolarization and ventricular systole, and this occurs at the ST segment. Pause the video and think about when would the atrial repolarization occur, and can you visualize this on the EKG below? If you look at the video in the right-hand corner of the screen of the heart contracting, you should notice that while the ventricles are contracting, the atria are relaxing at the same time. So if we know that the QRS complex represents ventricular depolarization that leads to ventricular systole, then it should also represent atrial repolarization that leads to atrial diastole. This is true, but we cannot visualize it on the EKG. If you notice the heights of the P wave in comparison to the QRS complex, the P wave is much shorter. This is because ventricles must contract much more forcefully than the atria for blood ejection. So the repolarization peak at the P wave is really just not noticeable in the EKG due to the sheer height difference. Finally, the T wave represents ventricular repolarization that occurs due to the cease of depolarizing stimulus from the AV and Purkinje fibers. Ventricular diastole once again occurs slightly after repolarization and lasts immediately after the T wave until the P wave. So now that we've reviewed all of the major landmarks of an EKG, I want you to take a look at this Wigger's diagram. So here we have the EKG portion of the chart, but we can also see what's going on with ventricular volume and ventricular pressure. This may be a bit of a challenge, but I want you to consider the cardiac physiology you've learned in your physiology courses, and also what you've learned today about EKGs, and see if you can unravel this diagram. I find it helpful to place my pin on a certain point on the EKG portion and then trace the pressure and volume that coordinates to this region and work through how these conditions may fit into a certain stage of the cardiac cycle. So pause this video and assign steps of the cardiac cycle to each segment on the EKG. Feel free to rewind the video and take as much time as you need. As we've discussed, EKGs are a very valuable clinical tool in diagnosing cardiac abnormalities, and now you know enough about them to diagnose your own patients. I want you to take a look at each of these EKGs and determine if it is normal, and if not, what could this abnormality indicate about the patient. The first EKG definitely does not look normal. You can see here that the space between the P wave and the QRS complex is very long. This circles back to the question earlier in the video about what would happen if signal was disrupted between the atrium and the ventricles. This is called a first-degree atrioventricular block and is marked by a long PR segment. So this occurs when electricity cannot effectively cross from the atria to the ventricles. This next EKG looks very normal. You can clearly see a P wave, a QRS complex, and a T wave, and they are separated at nice normal intervals. A patient with a normal EKG has what is called normal sinus rhythm. And finally, the last EKG looks like you can see all of the landmarks, but they do occur at too close of intervals, back to back with no pause. This is called tachycardia, which means that the patient has a very high heart rate due to this fast firing of electric signals.